The broadcast is now starting. All attendees are in listen-only mode.
Hello, my name is Mike Willett at the Intertribal Council of Michigan's National Native Network. Welcome to the NNN webinar series on cancer risk reduction in Indian Country. This webinar is titled Colorectal Cancer and Diabetes Cancer Risk Factors. This technical assistance webinar is being hosted by the National Native Network with the Indian Health Service Health Promotion and Disease Prevention, which offers technical assistance and resources for commercial tobacco prevention and control throughout Indian Country, and the Indian Health Service Clinical Support Center. Your presenters today are Dr. Durado Brooks, MD, and Dr. Lani Desaulniers, MD. Dr. Brooks is Vice President of Cancer Control Interventions at the American Cancer Society. He earned his MPH in 1999 from Harvard School of Public Health. And Dr. Desaulniers is the clinical consultant at the Hill Group and at the Indian Health Service Division of Diabetes Treatment and Prevention. In 1985, she earned her family medicine residency at the University of North Carolina at Chapel Hill and her MD at the University of California in San Francisco. We're pleased to offer continuing education credits for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated one contact hour for nurses and physicians. And to obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. By the end of this webinar, participants will be able to recognize common risk factors for colorectal cancer and barriers to colorectal cancer screening, and utilize appropriate strategies to address those risks and barriers, integrate key practice change elements and evidence-based CRC screening resources and practice to assure appropriate management of individuals at average and increased risk for CRC. Identify the cancers that are most commonly seen in American Indians and Alaska Native people in the United States, and those that are associated with diabetes. And describe trends in diabetes care and outcomes in American Indian and Alaska Native people in Indian health that supports the value of population-based care and screening. If you have any questions, please type your questions into the question box on the lower right-hand side of your screen. Questions will be answered during the last few minutes of the webinar. And now at this time, I present to you Dr. Brooks.
Thanks very much, Mike, and thanks to the Intertribal Council of Michigan for inviting me to be part of this presentation. I am not seeing the little arrows down here. There they are. All right. So I'm going to be talking about colorectal cancer and colorectal cancer risk factors, and in particular how they affect the American Indian Alaska Native population. Just for a little level setting, I'm sure that everyone on the line is familiar with the colon, which is also called the large bowel or large intestine. Long muscular tube, about 5 feet long, absorbs water and salt from food and stores waste matter. And then the rectum is the last 6 inches of this tube. The colon and the rectum have somewhat different structure. They have somewhat different treatment for colon versus rectal cancer. but the underlying risk factors and causes for colon and rectal cancer are essentially the same. Consequently, we usually talk about the two of them in one. So when we talk about colorectal cancer in the US, it is the third most common cancer and the second leading cause of cancer death. Over 145,000 new cases will occur in the US this year, and more than 51,000 US citizens are going to die of this, or individuals in the US. There is significant risk variation by race and ethnicity, and I'll talk about that. In particular, Alaska Natives have extremely high rates of colorectal cancer, as do American Indians, but there's variation depending on where geographically one is located as to whether the risk is higher or indeed lower than that seen in the white population. African Americans across the US also have very high rates. So these groups have the highest rates of both diagnosis and death of all groups in the US. On the other hand, Hispanics in general have a significantly lower rate, although again, we see variation in the incidence and mortality rates depending on the country of origin for the Hispanic population. And we don't have any clear explanations for these racial, ethnic, or geographic differences, but they're very real. When we look at mortality trends across, really going back almost 30 years, we've seen a pretty steady downward trend in colorectal cancer mortality across the US. The blue line here is the white population, and you can see that that line is trending down very steadily. The red line is the African American population. For many years, it was said that African Americans had the highest rates of all groups in the US. Part of that may simply be because we didn't have really good data on the American Indian Alaska Native population. That's that purple line that is there. And you can see that line jigs and jags up and down. It's not because there's tremendous variation from year to year in the mortality rates. It's because our data collection has not been really good for these populations. We're doing a better job in recent years, and you can see that the rates are higher than the white population. However, this looks at American Indians and Alaska Natives as a monolithic group. When we actually break out by different factors, then we see a very different picture. So this is, I'm sure that most folks on the line are familiar with the CHSDA counties, the contracted health services breakdown that is used by Indian Health Service in particular to define different groups. This is colorectal cancer incidence based on CHSDA County. And as you can see, there's tremendous variation, with Alaska having extremely high colorectal cancer incidence rates, and the rates being higher in most regions than the white population, which are these lighter pinkish bars. Although you can see that in the East region, as well as in the Southwest region, the white population rate is actually higher than that of the American Indians in those regions. But if you look at the map, you'll see that the East region in particular is huge, and there is variation even within that group, within that population. However, when we look at, okay, the arrows have disappeared again, Mike. There they are. When we look at colorectal cancer mortality, the picture is similar, but there are some significant differences. Again, Alaska Natives, absolutely the highest mortality. Most of the American Indian population across the US has higher mortality. And even in the East, where, remember, the incidence rates were lower among American Indians and the white population, the mortality rate is still higher. So even though Indians are less likely to be diagnosed in the East with colorectal cancer, they're still more likely to die from the disease. The Southwest is the only region where there actually is both lower incidence and lower mortality than that seen in the white population. Again, the reasons behind these racial, ethnic, and geographic differences are not clear. but there is a fair amount of work going on trying to determine what could be leading to these differences. There are a number of important risk factors for colorectal cancer, with age being the predominant risk factor. Nearly 90% of colorectal cancers occur in people over the age of 50 in the US. However, this is changing, and I'll talk a little bit at the end about some of the changes that we're seeing. But this statistic is the reason for many years that 50 was the recommended starting age for colorectal cancer screening, although many of you are probably aware that the ACS has actually lowered that to age 45. In addition to age, diet also plays an important role. Diets high in red meats, processed meats, increase your risk of colorectal cancer. Diets high in fresh fruits and vegetables, plant-based sources, actually lower colorectal cancer risk. Other risk factors include a lack of physical activity. Being overweight, and in particular being obese, increases the risk both of being diagnosed with colorectal cancer and the risk of dying from it. Smoking, heavy alcohol use, both increase risk. And then finally, type 2 diabetes, which I'll talk about in a little more detail, is also known to be a risk factor for developing colorectal cancer. With regard to the colorectal cancer diabetes link, one thing that has been known for a long time is that there are a number of shared risk factors. So many of the things that I just mentioned, obesity, lack of physical activity, diet, heavy alcohol use, tobacco use, are all associated either with diabetes or with complications in people who have diabetes. And then insulin resistance and hyperinsulinemia are known to be risk factors for colorectal cancer. So when we start looking, it goes beyond simply sharing risk factors, though, and it turns out that type 2 diabetes is an independent risk factor for the development of colon and rectal cancer. Also, a number of studies indicate that among people who are diagnosed with colorectal cancer, that those who have diabetes are more likely to die, even when you control for other things like body weight and smoking habits. Diabetes is also linked to a number of other cancers, including pancreas and breast and liver cancer. And I believe that Dr. Desaulniers will be talking a little bit more about those links. This is, whoops, these arrows are really sensitive. This is a meta-analysis published a number of years ago that looked at a large number of studies that had studied the association between diabetes and colorectal cancer incidence, and overall found about a 30% increased risk for colorectal cancer among people with type 2 diabetes. A number of other studies and more recent studies actually have looked at this, and that 30% increased risk seems to be pretty steady throughout the literature. So why does diabetes increase the risk of developing colorectal cancer? Well, as I'm sure most on the line know, insulin is how the body regulates the amount of sugar in the bloodstream. And diabetes is characterized both by elevated blood sugars, hyperglycemia, as well as in type 2 diabetes, high blood levels of insulin or insulinemia. And it's theorized that these high levels of insulin and high levels of glucose are somehow carcinogenic toward the colon as well as other parts of the body. There are other working theories also having to do with chronic inflammation. And we do know that inflammation is an important component of the organ damage that occurs to patients with diabetes that result in diabetes-related complications. We also know that inflammation plays a very important role in the initiation and progression of colorectal cancer. So some inflammatory response related to hyperinsulinemia or hyperglycemia, or both, may also be playing a role. So this is what I thought was a really interesting and useful graphic, just pointing out that there are a number of important common risk factors across both diabetes and colorectal cancer, but in the combination of insulin and obesity and diabetes, all of those are known to have carcinogenic components, and all of these lead to hyperglycemia, inflammation, and ultimately both to diabetic complications as well as cancer in the colon and other organs. So there are some other risk factors for colorectal cancer that are also important to recognize. And it's thought that 2 or 3 out of every 10 adults, so somewhere between 20 to 30% of adults, have a major risk factor. That is a risk factor that increases their risk of developing colorectal cancer even more than things like diabetes or even more than racial differences. One of those major risk factors is the polyp. Now, there are 2 major types of polyps, one being hyperplastic polyps. And actually, hyperplastic polyps have a very low risk of developing colorectal cancer. So if you have a patient who has a colonoscopy and all that's found are 1 or 2 simple hyperplastic polyps, that patient is still considered to be at average risk of developing colorectal cancer and actually does not need any other screening for 10 years. If it was a well-done, high-quality colonoscopy and a complete colonoscopy to the cecum, that patient does not need stool test in between. They don't need another colonoscopy. They're good for the next 10 years. On the other hand, the adenomatous polyp is a significant concern. About 9 out of 10 colon or rectal cancers are believed to start with an adenomatous polyp. And consequently, patients who have adenomas found at the time of screening are going to need to have much closer follow-up. And surveillance colonoscopy after removing simple adenomas is usually somewhere in the next 3 years. But depending on the histology, depending on how many polyps are found, sometimes it might even need to be, the follow-up may need to be sooner. But certainly you don't put people on a 10-year follow-up if adenomatous polyps are found at the time of colonoscopy. The good news is that the polyp gives us a chance to actually prevent cancer, because the transition from normal colon to adenoma to full-blown invasive cancer is usually a long period of time, somewhere in the range of 7 to 10 to as long as 12 to 14 years. And most adenomas actually never progress to cancer, but there are certain types of adenomas, and that's why it's important to know what the histology is, that are much more likely to progress. But in most instances, we've got this long window of time during which, if we are screening patients regularly, we can detect, remove the polyps and totally prevent cancer. Now, in addition to patients being at high risk if they have this personal history of adenomatous polyps, patients who have had colorectal cancer in the past are at higher risk of developing it again, so they need to be followed very closely. Your patients with inflammatory bowel disease, once they've had about 7 years of active disease, either ulcerative colitis or Crohn's, also have a strikingly higher risk of developing colorectal cancer and therefore need to be followed very closely. And then family history is also a very important risk factor that unfortunately in many settings is overlooked. Just about every environment will ask about whether or not a patient has a family history of cancer, but oftentimes that information is captured the first time the patient is seen in the practice, and then nobody ever even looks at that information again. So if an individual has a family history of colorectal cancer, it's also important to dig deeper and find out, is this cancer that occurred in their great-grandmother when she was 85? If so, probably not much impact on your patient's risk. However, if your patient had colorectal cancer diagnosed in their mom, dad, sister, brother, then their risk is at least doubled. If that relative was diagnosed at an early age, then their risk is potentially even higher, or if multiple relatives have been diagnosed with colorectal cancer. In addition, the other thing that is seldom asked is a family history of adenomas. Yet, a family history of adenomas in a first-degree relative is thought to at least double the risk of colorectal cancer. So it's important to be collecting that information and acting on it appropriately. And then there are the hereditary syndromes, adenomatous polyposis, Lynch syndrome, etc. For patients who have any of these risk factors, they need to be identified early in your practice. You can't wait until people get to be 45 or 50 years old to start assessing their colorectal cancer risk, because if they've got these risk factors, they may need to start screening at a strikingly earlier age. For instance, patients with Lynch syndrome are at risk of developing cancer in their 20s. So they need very early screening to start. If a patient has a family member, particularly a first-degree family member diagnosed with colorectal cancer at age 50, that patient needs to start screening 10 years before their relative was diagnosed. So that means they need to start screening at age 40. If you're not asking about colorectal cancer risk factors until people are in their late 40s or 50s, we're missing many opportunities. So it's important to be collecting this information early on and acting on it. Now, another very important thing to keep in mind is we've seen a dramatic shift in the epidemiology of colorectal cancer over the last 30 years or so. There's been a dramatic increase in diagnosis under the age of 50. As a matter of fact, a 51% increase in early age diagnosis since 1994. So, and the majority of these cases are occurring in people in their 40s, so between 40 and 49. However, a significant number of people in their 20s and 30s are now being diagnosed with colon and rectal cancer. And many of these folks do have a family history that should have stimulated earlier screening, but that's actually the minority of these early onset patients. More than half of them don't have any identifiable risk factor, but they're still being diagnosed with this disease at very early ages. This looks at early onset disease by race and ethnicity, and you can see the trend is upward for essentially all groups. Those groups clustered at the bottom are Hispanic, Asian Pacific Islander, and non-Hispanic whites, and you can see the trend is heading upward for all of those groups. That purple dashed line is the African American population, and it's been known for many years that African Americans were more likely to be diagnosed before the age of 50, and their rates overall are actually not trending upward. They're fairly stable, but you see they're still higher than almost every other group. However, that orange line at the top that is rising so dramatically, that's the American Indian Alaska Native population. And the rates of under 50 diagnosis in that group are literally climbing off the chart. So why are we seeing these kinds of trends? And we don't know. That's the sad truth. There are a lot of theories about what may be contributing, and actually these potential contributors come back to some of the factors that I talked about earlier with regard to the diabetes, colorectal cancer risk, risk factors for diabetes and for colorectal cancer. We know we've seen very, very dramatic rise in obesity over the last 30 plus years here in the US. Increased intake of red meat and processed meat, increased rates of type 2 diabetes. Whether these are contributing to this early onset disease as they are to the later stage disease is not entirely clear, but at least this is a theory. They may be accounting for part of this rise. Antibiotic use, one of the things that I didn't mention specifically with regard to the diabetes and colorectal cancer risk is the question of how the gut microbiome may be changed by diabetes, and how some of those bacteria that traditionally live in the gut might be protective and may be wiped out by or damaged in some way by hyperinsulinemia or by hyperglycemia, or they may be being wiped out because of excessive antibiotic use, which we know is a big problem in parts of the US. So there are a number of theories about why these trends may be happening, but we don't have any real good answers. There's a lot of research underway trying to figure out So what can we do? The best thing you can do to help lower the risk of colorectal cancer in general is screening. Now, when it comes to younger individuals, it's important to recognize screening recommendations like these on the screen are for people who have no signs or symptoms of disease. Screening is for people who may be at risk of developing the disease usually because of age, but don't have any signs or symptoms. If an individual is symptomatic, screening recommendations are not relevant. I will tell you that because of my work, I meet a lot of colorectal cancer survivors, people in their 20s and 30s, or who were that young when they were diagnosed. And most of them talk about having symptoms, abdominal pain, weight loss, blood in their stool, oftentimes going on for months, oftentimes having been seen in the emergency room or seen 2 or 3 times by their doctor, and their complaints not being taken seriously. It is imperative that if you see patients who have symptoms, that if they were 60 years old, you would automatically think about colon cancer. Even if that patient is 30 years old, you need to still consider colorectal cancer in your differential and strongly consider sending them for a colonoscopy, because this early onset disease is real and it is common. Now, for the screening age population, then screening recommendations are directly relevant, and everyone in your practice should start having a conversation about getting screened for colorectal cancer no later than age 45. Because of this trend that we've seen in early onset disease, the American Cancer Society, as of June of 2018, recommends colorectal cancer screening for all average risk men and women beginning at age 45. We also recommend that patients be made aware that there is more than one option for screening. One of the things that we found in our research is many patients who are not screened aren't screened because they believe colonoscopy is the only screening test available, and either they don't have access to colonoscopy or they don't want to have a colonoscopy. Simply making people aware that there are other high quality tests. Many of the stool tests that are available in the marketplace now function very well. And making patients aware that there are simple tests they can do at home, just collecting a stool specimen at home, can help increase the likelihood of patients getting screened for colorectal cancer. So making sure patients are aware and are offered the opportunity to be screened either with an invasive test like colonoscopy or with a simple stool test. But don't settle for no just because someone says they won't have a colonoscopy, or you make the appointment and they don't show up. Make sure that your patients know that they have options. Now, the other things that you can do, both to lower your colorectal cancer risk as well as to lower your overall risk of diabetes, risk of heart disease, are simple things like eating right, eating a lot more fresh fruits and vegetables. A lot more of your diet should come from plant-based sources and less from meat, particularly red and processed meat. Trying to maintain a healthy body weight, being active, exercising at least 30 minutes, 5 or more days each week. And exercise doesn't have to mean getting out riding a mountain bike. Walking, gardening, any sort of regular physical activity pays dividends. Limit alcohol use. No more than 2 drinks a day for men and no more than 1 drink a day for women. Vitamins like calcium, magnesium, may have some impact, but the evidence is not clear. We do know that non-steroidal anti-inflammatory drugs like Motrin, Naproxen, Aleve do have a salutary impact on the development or the progression of adenomatous polyps. And there's a pretty clear body of evidence now that the risk of colorectal cancer can be lowered with regular aspirin use. However, aspirin does have potential side effects. So this is something that you have to weigh on an individual patient by patient basis. The U.S. Preventive Services Task Force actually, maybe 3 years ago now, published a recommendation for aspirin use primarily around heart disease. However, within that same recommendation, it does mention the prevention of colorectal cancer as one of the impacts of regular aspirin use. So if you're not familiar with that recommendation, I'd encourage you to take a look at it. And then female hormones, estrogen, estrogen replacement therapy, or estrogen and progesterone, also have been associated with lower colorectal cancer risk. However, as you're well aware, there are potential other complications associated with those medications. So it needs to be a discussion between physician and patient. So thank you all for listening, and I'll be happy to take questions after Dr. Desaulniers shares her information. Mike, you're going to switch over to Dr. Desaulniers?
Yep, I just handed over control of the webinar to Dr. Desaulniers, and let's see here.
Well, good afternoon. Mike, are we okay? Can you hear me?
I can hear you.
Oh, okay, good.
Yeah, I can hear you just fine. I usually
Awesome.
put myself on mute for background noise. Go ahead.
Super. Well, I'll be spending the next section just talking about diabetes and cancer in American Indian and Alaska Native people. And fortunately, Dr. Brooks has done quite a bit of my work for me, which is great. So, but I want to begin actually by thanking the council for inviting me to join you today. Again, I'd love to thank Dr. Brooks for giving us a really great overview on diabetes and colorectal cancer. And then also to thank each of you for joining us this afternoon, because I'm sure you're all very busy. So what I'll be doing in the next little while is just giving a very broad overview on what we know and we don't know about diabetes and cancer in American Indian and Alaska Native people. And then I'm going to transition to something that's a little bit different, to talk with you about our experience in Indian Health Service in our diabetes program and how, implementing standards of care and screening protocols has really helped impact health outcomes over time. So it's a little bit different twist, but as we kind of think forward to what you might do in terms of cancer screening, perhaps some of our experience might be helpful to you. Sorry. Mike, is there something I need to do here? I got me. Here we go. Cool. Anyway, as we think about diabetes and cancer, they're both really common chronic diseases in our population. They have a really tremendous impact on everyone's health, both the physical, psychological, as well as spiritual health. And clearly there are genetic, environmental, and epigenetic factors at play in the manifestation of these. But as, again, Dr. Brooks well outlined, there are lifestyle factors that significantly influence the development and our outcomes. The increased risk with overweight and obesity is really important. Interestingly, there is some evidence from bariatric surgery that losing weight may decrease risk of GI cancers. There's clearly increased risk with smoking, and in the case of diabetes, increased risk of complications in people with diabetes who smoke. But smoking cessation significantly decreases risk. Screening can result in better outcomes for both. Early detection in asymptomatic phase can lead to much more effective interventions. This is just the most recent data on the prevalence of diabetes in American Indian and Alaska Natives. And as you can see in the bar over on the left, we're looking at an overall prevalence of about 15%. That risk is the highest of anyone in the country. We also see the rates of about 35% in our elders and 23% in the 45 to 64-year-old age group. The good news about this is that we're actually seeing improving trends in American Indian, Alaskan Natives. The diabetes prevalence leveled off in 2011 for adults and leveled off about 2006 for youth. So this is pretty encouraging. As a corollary, we're also seeing obesity rates in American Indian, Alaska Native youth between ages 2 and 19 has been stable for the last decade. So that's a good news story for us. When we think about cancer in American Indian and Alaska Native people, again, Dr. Brooks really well outlined the story with regard to colon cancer. I refer you, if you're interested, to an excellent publication in the American Public Health Association Journal, which dedicated an entire supplement in 2014 to health disparities and many articles on cancer in American Indian and Alaskan Natives. They looked at a data set from 1990 to 2009. So as Dr. Brooks well elucidated, there was a higher incidence compared to white US population in colon cancer, as well as many other GI cancers, also kidney, uterine, cervix, and lung, and higher mortality rates in many of those cancers. But what was really striking was the significant regional variation in incidence and mortality. And again, these are very well chronicled in this publication. I might add also, I've got a list of references and resources at the end. So if you wish to download the PDF, you'll have access to all of those if you want to read more about this, because it was a very well done publication. And if you want to see more contemporary data, the states do keep cancer registries, and many of them release information on incidence and mortality state by state that's broken down by race and ethnicity. Interestingly, no one really has specific data on diabetes and cancer in American Indians and Alaska Natives. But what we do know about diabetes and cancer in general is that there is an increased risk overall of cancers and diabetes. The liver, pancreas, and endometrium, we see a 2 times increased risk. Colorectal, esophagus, kidney, and bladder, 1.2 to 1.5 times increased risk. Again, the reasons for this aren't clear. Some epidemiological studies done in Europe and in Korea have looked at hyperglycemia and increased risk. They've variously looked at either fasting blood sugar, A1C elevations, and identified a linear increase in risk with higher blood sugars. No one knows really what that means. Again, there is increased mortality for people with diabetes and breast and colon cancer. Whether that has any connection to hyperglycemia, no one knows. Whether there are other comorbidities that are at play that influence the treatment options, again, it's not clear, but it certainly is a matter of concern. There's been a lot of look at the role of diabetes medications in cancer risk. Metformin, of course, is our go-to drug in type 2 diabetes. And interestingly, there's been quite a bit of observational data that's associated it with decreased risk and decreased mortality. There are some known anti-neoplastic effects. It's known to inhibit tumor cell growth in vitro. There are actually multiple ongoing studies now at the National Cancer Institute looking at the use of metformin as a preventive agent or an adjunctive agent in cancer treatment. This is all pretty good for a drug that was derived from a plant that grows in France that was used as a folk remedy for many, many decades and years. When we think about the thiazolidinediones, there has been some conflicting evidence that it may decrease risk of colon cancer, but this isn't clear. the pioglitazone is associated with an increased bladder cancer risk. With the incretin-based therapies, liraglutide, dulaglutide, exenatide ER, have been associated with increased thyroid C-cell tumors in rats. And so there is a precaution about prescribing these in people who are at risk for thyroid cancer. There's been a long-standing concern for increased pancreatic cancer risk because these drugs do lead to beta cell proliferation. There's no clear evidence this is connected to pancreatic cancer to date. Insulin, as Dr. Brooks mentioned, is a more complicated story. There's a theoretical risk due to insulin and insulin growth factor receptors on cancer cells. But many patients with type 2 diabetes have had long-standing endogenous hyperinsulinemia, so it's difficult to separate out the effects of the medication from the endogenous state. There was about a decade ago a concern about an increased risk with the use of our insulin analogs, such as Lantus, but that evidence to date is also inconclusive. Again, as Dr. Brooks mentioned, well, obesity is associated with increased cancer risks. And the cancers that are associated with obesity overlap greatly with the cancers associated with diabetes. What I've done here in the top set of bullets is listed those cancers that are associated with obesity and put an asterisk next to those that share that increased risk with diabetes. So we see a 2 to 4 times increased risk of endometrial cancer with obesity, but that increase in risk can go up to 7 times in women who are severely obese. And those rates are higher than what you see in diabetes alone. Stomach, esophagus, liver, and kidney, again, a 2 times increased risk, higher than what you see in diabetes alone. And the others, colon, gallbladder, breast, and pancreas, are more similar to the diabetes risks. Again, as Dr. Brooks mentioned, there is now a concern with the increasing rates of obesity in our population about that impact on cancer trends. There was a recent study published in Lancet Public Health, which was looking at obesity-related cancers, and they identified an increasing incidence of kidney, uterine corpus, colorectal, gallbladder, pancreas, and multiple myeloma in the 25 to 49 year age cohort, and steeper rises in the younger cohorts. So this is certainly something that we need to be concerned about over time. Just as an aside, early in my training, endometrial cancer was primarily a postmenopausal disease, and now it is being seen more commonly in younger women. So it's something our women's health providers have to be aware of when they're treating premenopausal women who are obese, who have very heavy bleeding. So again, clearly diabetes, cancer, and obesity are commonly seen in our communities. As we think about efforts to improve cancer screening, they can be challenging. But with that said, I just want to share with you a little bit about our experience in diabetes care that really demonstrates the value of population-based screening. So I worked for decades with the Indian Health Service, with the diabetes program, and now I serve as a consultant for them. So this is my full disclosure. But I wanted to share with you that long ago, when the diabetes program was first established in the late 70s and early 80s, they identified the need to provide a set of standards that could be used across Indian country to help improve the care and treatment of people with type 2 diabetes. And they established a set of Indian Health Service standards of care and practice recommendations that included recommendations for screening and clinical care. And this predated the American Diabetes Association guidelines of the same name. With that, flow sheets, clinical reminders were developed, and we established a diabetes care and outcomes audit, by which we've been tracking information for well over 30 years about care and outcomes throughout Indian Health Service. And I might add that most of this in the early years was done on paper, so it was quite a feat. In 1998, the special diabetes programs for Indians came into being. These were programs that were funded that gave grants to tribal communities throughout the nation. And they began to work on diabetes prevention in their communities, promoting health. They were engaged in screening and working with children for childhood obesity treatment and prevention. And they began to play a big role in the care of people with diabetes in the communities. They used information from the audit to track their outcomes as well. So again, there have been many hands at work in the last 2 decades in terms of improving the care of diabetes in Indian health and in American Indians, Alaska Natives. So I just wanted to share with you 2 of the trends that we're pretty excited about. Surely diabetes kidney failure is one of the most devastating complications. 2 years ago, we had a publication in the MMWR, which actually looked at trends in the end-stage renal disease among American Indian, Alaska Native adults. And what you can see on the slide is that back in 1996, there were the highest rates of kidney failure from diabetes seen in American Indian, Alaska Natives. And over a span of 17 years, those rates have declined 54%. And this has been a really encouraging story, but really good news for our communities. As we were able to look at some of our data, we were able to see that we were achieving very good blood pressure control, that the average blood sugar control improved modestly over that period of time. The use of kidney protective medications was very high relative to an equivalent NHANES population, and that screening for kidney disease, doing urine protein testing, we were doing that at a much higher rate than was seen in an equivalent Medicare population. So those are some of the factors that we feel have played a role in terms of these outcomes. Diabetic retinopathy, lastly, is one of our also devastating complications. In 2000, the Joslin Vision Network established a teleophthalmology program in conjunction with IHS, and retinal cameras were provided to sites rural and urban across Indian country. There was a study published last year that just looked at a retrospective analysis of the imaging done in 54,000 people via that program, and noted that there was a significant decrease in retinopathy and macular edema seen in that population. So again, encouraging to us that over the long run, some of our efforts have paid off. So just to conclude, diabetes and cancer are 2 chronic diseases that had a significant impact on health in American Indian and Alaska Native communities. But that population-based care can improve outcomes. In an era when our QI projects are often very short-term, it's important to recognize that we should be thinking about improving our outcomes in the long term. And perhaps what we've been doing in diabetes is a model that others could use to think about screening their communities. So the last thing I just want to share is these are the references which you're not likely to be able to read, but if you're interested, you can download the PDF. And here's a set of resources that I wanted to just share with you. Trends in Indian Health is a publication on the IHS website, covers a lot of trends about overall health in Native people. The National Native Network, of course, has great cancer resources, as does the CDC. And lastly, I just want to plug our own website, the Indian Health Service Division of Diabetes Treatment and Prevention. There you'll find the Indian Health Service standards of care, some clinical care algorithms, outstanding diabetes educational materials, and also it's a source of free CME. We have a series of live and pre-recorded webinars that you can get free CME credit for. And there's actually a concurrent session going on diabetes and nutrition today. We also have an upcoming conference in Oklahoma City from August 6th to 9th. And this is being co-sponsored by the IHS Chief Clinical Consultant and our diabetes program. There'll be outstanding CME for 3.5 days. It's free. The lodging is pretty cheap. And the first topic is all primary care, and the next 2.5 days are about diabetes. So I invite any of you to attend and join us this summer. Thank you very much.
Alrighty, thank you very much, Dr. Desaulniers and Dr. Brooks. So at this point, if you happen to have any questions, feel free to type them into the question box. We'll do a Q&A session all the way up to the top of the hour here. So feel free to go ahead and type in your questions. In the meantime, while that's going on, we will be uploading an archive of the webinar up on our website at keepitsacred.org. So if you have any colleagues that are interested in checking out a recording of the webinar, visit keepitsacred.org. We'll have it up in the next 24 hours. And then also keep an eye on our social media, especially on Facebook and Twitter. And we'll post when we do get the webinar posted up on the website. We should hopefully have it up later on today, but just in case anything happens to go wrong, I like to say that it'll be up within the next 24 hours. We also have other resources, toolkits, and all that sort of stuff up on our website as well. So feel free to type your questions into the question box. And in the meantime, Dr. Desaulniers or Dr. Brooks, did you have any other comments you wanted to add?
No, nothing for me. I appreciate the opportunity to share this information, and I really learned a lot from Dr. Desaulniers.
Well, likewise, I learned a lot from you, Dr. Brooks. So there's a lot of overlap in what we do.
Alrighty, so I still haven't seen any questions come up yet. If you have any questions, feel free to type them into the question box and just hit the enter button there. Yeah, so we'll stand by here for the next minute or two, see if there's any questions that come up. And I'll show off Dr. Desaulniers' references there again and plugs. Alrighty. Well, we don't have any questions being filled in yet, so looks like we might have a chance to maybe cut the webinar early. So, with that in mind, we'll go ahead and wish everybody an excellent day and a wonderful spring here. And thank you very much. And feel free to keep an eye on your email in the next 24 hours as well. Our post webinar evaluation will be sent out there. If you could go ahead and complete that, then we'll go ahead and make sure that we get CE sent out to everybody within about 6 weeks. Thank you very much, and I hope you have yourselves a wonderful day.
Thank you. Bye-bye.
Thank you.